Good afternoon and welcome to this teleconference hosted by MS Focus, Multiple Sclerosis Foundation. I'm your host, Chris Payne, editor for MS Focus, and I'm joined by Dr. Ben Thrower, who will be answering your questions today during this month's session of Ask the MS Expert. Now, I'm very delighted to introduce our speaker. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for MS Focus, the Multiple Sclerosis Foundation, and enjoys contributing to our quarterly MS Focus magazine. We're pleased to have him join us to answer your questions. Dr. Thrower, thank you for being with us, and I will turn it over to you.
Wonderful. Thanks very much, Chris. And thank you to everyone at MS Focus for all the work that you folks do and the support that you give to the MS community and MS providers. So this is, as I've said before, is one of my favorite things to do. So we have no set agenda. We will talk about whatever people want to raise as a question or concern. So with that, why don't we throw it open to some questions?
All right, as we do, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. You can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you are on the phone. I will call on you and then you will be able to unmute to ask your question. And we already have a couple of questions here. Let's start with Gus. Do all MS patients progress or have issues with heat sensitivity, balance, bladder, foot drop, etc.? I ask selfishly as I have been diagnosed for 9 years. I am currently taking a low efficacy DMT, Plegridy, and have an EDSS of 1, and I have none of the issues stated by many with multiple sclerosis. Do these problems eventually occur in the future to MS patients?
That's a great question, Gus. And I think one of the things that your question raises is the highly variable nature of MS from one person to one person. So we always have to be careful in generalizing with multiple sclerosis because your story is your unique story. We know that not everyone with MS follows an aggressive course. We used to talk about the rule of thirds, and this was in the days before there were any MS therapies whatsoever, that about a third of people with MS were going to follow this very mild course. And at age 90, they're going to look back over their life and say, you know what? This was a curious nuisance. I had some funny things come up, but I really didn't accumulate, any significant issues over the years. There was a middle third that was going to have some issues, when they look back over their life. And then there was a third that really had a much more aggressive course. All of those things still hold true, but hopefully we've changed that dynamic with the disease-modifying therapies. So the symptoms that you raise are all very common things we see with MS, but you may not experience those things. We do know that how you're doing after 5 years and 10 years of diagnosis is very predictive of probably what you're going to do over time. So the fact that you're at a very low EDSS of 1.0, would tend to predict good things for you going forwards. Yeah, so best of luck.
All right, we have Karen up. Karen, as soon as you're ready.
I'm ready, thank you. I've had MS, been diagnosed for 3 years. I'm 64. And on Saturday night, I had an episode where I fainted, syncope, and went to the ER. They did a whole workup and there were no no issues with my heart. Was this an MS episode?
Probably not. So syncope is, so if your blood pressure drops, you're not.
Yeah, I fainted. Yeah.
So we don't normally think of that as a direct result of MS. Now, that said, some people with MS have autonomic dysfunction, so they may not regulate their heart rate or blood pressure normally, but it's unusual to see outright syncope as a result of that. So, there are so many different things. You did absolutely the right thing. You want to go and get urgent care, rule out any big bad stuff from a cardiopulmonary standpoint. But sometimes syncope just is someone is, maybe has a combination of things that come together. Maybe you're relatively dehydrated. Sometimes medications can lower blood pressure a little bit. It's super hot outside everywhere in the US right now. So, hopefully it was a one-off event for you.
Okay, yeah, dehydration and heat were factors. So I'll go with your plan. Thank you.
Awesome.
Karen, enjoy your day. Our next question comes from Elizabeth. What are your thoughts on the current vitamin D recommendations to limit dosing and levels to 30 to 50, even in MS? Thank you.
So there's a little, bit of conflicting, thought on that right now. So there were a couple of studies that came out of Europe earlier this year that kind of ran counter to what we've seen with other studies. And so I think there are kind of two camps on vitamin D. I will say I'm in the probably more aggressive camp. I like to keep people's levels above 50. There are older studies that have suggested that levels above 50 were associated with a lower risk of relapses, a lower rate of new MRI lesions. These two Swedish studies didn't find it. There are other health benefits to vitamin D outside of just multiple sclerosis. So talk to your healthcare team. I would say, you may run into two camps. I get where the 30 to 50 people are coming from. They've got some data to support what they're doing. I think probably the most important take-home message is don't take mega doses of vitamin D blindly. Know what your blood levels are. Do it with some guidance, because too much vitamin D is not good either. So when we run people with levels above 100 for long periods of time, we do see some risk of depositing calcium in places in your body that you don't want it, like your kidneys or maybe even the coronary arteries. So don't do big doses blindly.
Just a reminder, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you are on the phone. I will call on you and then you will be able to unmute and ask your question. Next up, we have Judy. Judy, go ahead.
Hi, I'd like to know what you think about discontinuing.
Sorry about that. Sorry about that, Judy. That was a mistake on my part. Feel free to unmute and ask your question again. Again, I apologize.
Hi, I wonder what you think about discontinuing DMT treatments in old age. I'm 75 years old, and my neurologist suggested that I cut back by half on my dimethyl fumarate for 3 months and then maybe discontinue it entirely.
So that's been one of the hot topics here in the past few years. And so we've always thought that at some point people with MS can probably come off of their DMT. One question is why? Why is it that you can stop your disease modifying therapy? It's because of a biological process called immune senescence. As we get older, our immune systems kind of mellow out a little bit. And if you have an autoimmune condition, a health problem is driven by a relatively overactive immune system, a little bit of mellowing of the immune system is probably not a bad thing. We didn't have a lot of studies that looked at the hard data, but so there was the DISCO MS, discontinuation MS study that was published in the Lancet this year that tried to put some meat to this. They looked at individuals 55 and up. The bulk of people in the study were 60 and up. And so to get into the study, you had to have had stability for at least 3 years prior. No relapses, no new MRI lesions, no significant progression of disability. And what they saw in this study is that there really wasn't a huge difference between the people who stayed on and those that went off. There was maybe a slight trend towards maybe some more MRI changes in the group that went off. So we do have this discussion with people like yourself, about the risks and benefits of coming off of disease modifying therapies. I don't twist people's arms and say, you absolutely must do this. I think there has to be a comfort level. And what I see when I talk to people are two different types of people. Some people who are really anxious to get off their meds. Maybe they've been on one of the older injectables for a long period of time. They're tired of doing shots. Maybe they're having side effects with their DMT. Maybe there's a financial concern with staying on it. And then we see people who really are very kind of leery about stopping, and they really would probably lose sleep at night with stopping it. If they're on a drug with a fairly low risk and there's no big financial hardship, I'm not opposed to leaving that person on if they really feel like psychologically they would struggle with being off of it. So yeah, what your doctor's doing is perfectly reasonable. And it's really, it's a concept that's been around for a while, and now we've got some new data to back up what he's doing.
Thank you.
Yeah.
And thank you, Judy. We really appreciate it. Our next question comes from Julio. I hope I'm pronouncing that correctly. Any update on clemastine for MS?
Yeah, so this is one of those medicines that is being repurposed. There's a lot of interest in neural repair and reversing disability. And while there are a lot of different pathways we're looking at to do that, one pathway is trying to take existing drugs and see if maybe just by luck, they may have properties we weren't aware of. So clemastine is an antihistamine. The folks at UC San Francisco did a study in 50 people with optic neuritis, and they did see some recovery of vision in those 50 individuals. There's been an update here recently in those same 50 people. They did some specialized MRI studies to look for evidence of remyelination in one of the bigger white matter tracts in our brain called the corpus callosum. And they did see evidence of remyelination in the corpus callosum. So, there are larger studies ongoing with clemastine. I think those will give us a lot more information still. So it looks very promising. And the beauty of something like clemastine is we don't need to wait for FDA approval. If the data looks good, it's already FDA approved. We know the safety of the drug, and it's been around for quite a while.
All right, our next question comes from Michael. Michael, as soon as you're ready.
Dr. Throw, it's Michael Manfred. I've worked with you before.
Yeah.
It starts to do with spasms, and I discovered that I have a herniated disc on L4, which is putting pressure on my spinal cord. And when that happens, especially when I'm laying down, it'll cause my left leg to go into spasms. And I'm wondering, well, will the baclofen, once they get up to the level it should be, will that help eliminate the spasms? Or do I have to go through trying to eliminate the problem with the pressure on the spine?
So you raise a good point. So spasms and spasticity are very sensitive to noxious stimuli, something that irritates your body. It could be a clothing that doesn't fit well, a sock that's bothering you, a UTI, a nerve root that's irritated. So a disc bulge or herniation at L4, even though it's not directly causing the spasticity or spasm, because at L4, you have no spinal cord. Those are all nerve roots at that level. So it's pushing on a nerve root, but indirectly that irritation, the sciatic pain, can cause a secondary spasm. You may be able to quiet it though with the going up on the baclofen. If not, if it really is that turns out that disc herniation needs to be addressed, and that's where things like epidural steroids, or hopefully you don't have to talk about surgical intervention, but I would certainly exhaust every option out there before I go the surgical route.
Well, one person mentioned to me, or there's you could do high energy laser treatments on your back to help eliminate the pressure on the, or the
Yeah.
symptoms of L4. Have you heard about that?
Yeah, I think anything like that is certainly on the table. And the thing that's hopeful for someone like yourself is that disc material is about the consistency of Jell-O. So just like it can bulge out, well, it can go the other direction too. And sometimes all it takes is just, a fraction of a millimeter of the disc going the right direction to maybe relieve the pressure on the nerve root.
Okay, thank you.
Yeah, absolutely. Thanks.
Thank you, Michael. Enjoy your day. Our next question comes from Anonymous. What is the best medication to help the MS hug? I have the hug constantly in my abdomen, which varies in intensity throughout the day. I also get it in my throat, neck, nose, face, and mouth. Luckily, this isn't constant, but it happens frequently, especially in the summertime or when I am extra stressed. Is there anything out there that can make it go away completely?
So, MS hug is one of those things that, it sounds like it would be a pleasant thing to get a hug, but, like that person's describing, unfortunately, it's usually pretty unpleasant. We think the MS hug is a form of spasticity or spasm. So we would manage it generally like spasticity and spasms. Normally with spasticity and spasms, we think of physical therapy and stretching first. This is a form of a spasm that really doesn't lend itself to stretching very well. It's hard to stretch the muscles of your abdomen or chest or neck or throat. So usually it's going to be medications. And typically with spasticity and spasms, it's baclofen, tizanidine, our old standbys, medical cannabinoids or medical marijuana, and depending upon the state that you're in, could certainly be an option for dealing with that. In some people, we think the MS hug could also be something called central neuropathic pain. So if a person has tried out anti-spasticity treatments and they're just not getting where they want to be, then we may go the route of looking at things that we use for central neuropathic pain. And these are usually either antidepressant drugs that have been repurposed for pain management, things like Cymbalta or duloxetine, or they're anticonvulsant drugs that have been repurposed for pain management. So things like gabapentin, Trileptal, or oxcarbazepine, Tegretol, carbamazepine are things that can be used for central neuropathic pain. And again, medical cannabinoids do work for both central neuropathic pain and spasticity, so those could be an option for you as well. Usually we find something that's going to, make that, tolerable at least, and maybe eradicate the symptoms altogether. You bring up a good point that things like stress, heat, sleep deprivation, certainly infections, UTIs are going to make those symptoms kick up for you. So trying to control those factors as much as you can will help as well.
Once again, I'd like to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you'll be able to unmute and ask your question. And our next question comes from Anonymous. Can you build muscle through strength training, or does the demyelination counteract the ability to build muscle?
Great question. So the muscle shrinkage or atrophy that we see in multiple sclerosis is called disuse atrophy. So because you're not getting the signals to that muscle, you will tend to sometimes see the muscle shrink. The good news is it can be rebuilt. So if you can find ways to move that muscle, through exercise programs, there's even research using something called functional electrical stimulation. So if you can't get the signal to the muscle, we'll do it for you through an external device and stimulate that muscle. Those muscles can be rebuilt. You can regain strength up to a certain degree. One of the challenges, when we start people in rehab exercise programs, functional electrical stimulation programs, we never know how much can be rebuilt, but we certainly want to give it, 110% to see just how much improvement we can get.
we have another question, this one from Mary. I hear people talking about neuroplasticity improvement, but typically as it relates to brain lesions. I'm wondering if the benefits of neuroplasticity can also relate to spinal cord lesions. Thank you.
Yeah, so neuroplasticity is the idea that if I can't repair the damage, which we would love to do, new myelin, new axons, let's reroute, let's form new pathways around the area of damage. And we do think it's possible anywhere in the central nervous system, both in the brain and the spinal cord. So there was a device that got FDA approval late last year called the PONS neural stimulator. And this is an external device that's used during rehabilitation that we think may be promoting new pathways forming. If you look at the trials they did with that device, these were all trials looking at people with walking issues. And generally, we think of walking issues as being probably a little bit more of a spinal cord issue than a brain issue. So we do think that neuroplasticity can apply to the spinal cord as well.
All right, our next question comes from Ms. Coleman. And she has a question that is probably near and dear to the hearts of everyone. Hi, just in general, is there a question why DMTs are so expensive? Medicare and unfortunately not able to participate in the drug reduction programs offered by this pharmaceutical company.
Yeah, I mean, there's so many layers to that. So it's hard to know why these drugs are so expensive. When you think about biologic agents, things like the monoclonal antibodies, Tysabri, Ocrevus, Lemtrada, those drugs are very, very labor intensive to put together. So those are produced in cell lines. So that's a pretty tough process. Other medications like dimethyl fumarate, I mean, those are really simple molecules. And when dimethyl fumarate was name brand only, it was a little harder to kind of justify the price. There's always the research and all the regulatory stuff that goes into a medication getting approval. There's research and development that goes into it, but it is a tough one. What she mentions about Medicare, I think, is one of the most frustrating things out there. So, so many of our drugs are so expensive, but we usually have patient assistance programs. But those patient assistance programs, like she's saying, don't always apply to Medicare. In fact, that's the federal government, and in their wisdom saying, you're buying the federal health insurance patients' business by helping them with financial assistance, which is absolutely not true. There are some ways around that. So what some of the pharmaceutical companies do is, if you're a Medicare recipient, you will get your financial assistance through an independent nonprofit group. And so the pharmaceutical companies give money to the nonprofit, and rather than you getting direct assistance from the drug company, you're getting it indirectly from the nonprofit. It works. It's a bit of a hassle. It's a more paperwork and more phone calls to get on that program. One thing that has been nice here recently is with the Cost Plus online pharmacy. So this is Mark Cuban's online pharmacy. Some of our generic DMTs have become very, very inexpensive on that. So just paying for it out of pocket. Something like dimethyl fumarate, I believe, is about $50 or less per month. Fingolimod, generic Gilenya, is available there and is very inexpensive. So that's added one more potential option, just to go around insurance altogether and just do it inexpensively out of pocket.
Our next question comes from Linda from Facebook. Linda asks, my MS specialist dropped me because he thought I was a drug seeker because of my pain medications. I am now searching for another specialist and prefer telehealth because of my disabilities. Any thoughts?
Yeah, so most states now are really regulating how healthcare providers prescribe controlled substances, and especially with a real focus on opioids, your hydrocodones, your oxycodones, benzodiazepines like Xanax. So so most states now have some sort of registry where, so before a healthcare provider can write that prescription, we have to go onto a registry and make sure you're not getting early refills or meds from other people. So there is a level, I think, of nervousness on the part of healthcare providers that may not have been there before. You mentioned doing telehealth for controlled substances. That's probably going to be getting tougher and tougher. A lot of our ability to prescribe controlled substances via telehealth came on the heels of the COVID pandemic, and they really broadened out what we could do with telehealth. A lot of those things are going away now. And so it's very possible that it's going to become more difficult to do controlled substances by telehealth in the future. It may require at least some in-person visits. So not to be discouraging, but yeah, that's kind of the background behind what you're dealing with. That's I think the regulatory monitoring of what we do as healthcare providers has made physicians pretty cautious about how we do controlled substances, and they're going to start limiting the telehealth ability to do that.
Let me take this opportunity to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you'll be able to unmute and ask your question. Our next question comes from Anonymous. I haven't been diagnosed with MS, but I have fibromyalgia, rheumatoid arthritis, other immune diseases, and I have been experiencing over 20 MS-like symptoms for over 15 years. I can't get doctors to listen or believe me. Are there specific diseases that mimic MS that I should ask them to test for? I recently had an MRI that looked clear, but it was done without contrast.
So one of the challenges with diagnosing MS is that so many of the symptoms can be very non-specific, and you can certainly see them with other health conditions like fibromyalgia or other autoimmune conditions like rheumatoid arthritis, lupus, Sjogren's. So if you think about MS, so what's one of the most bothersome symptoms we see in people with MS? Well, fatigue. Fatigue is so non-specific. You can see it across so many different things. The challenge with MS also is we would like to get it diagnosed quickly, but we would also like to get it diagnosed accurately. You know, some of the, as we've moved into the era of more highly efficacious drugs, those drugs do come with more side effect risk, including the potential for immune suppression. So we want to make sure that we're putting people on the medication appropriately and not exposing people to risk unnecessarily. I think if you have a normal MRI of the brain 15 years into your symptoms, the likelihood that it's MS it's not zero, but it's very low, even without the contrast. So what contrast really does is it lets us tell whether a lesion is active or not. It's going to show whether there's active inflammation. We will still see the lesion without the contrast. With newer MRI techniques, there was just a study that showed that radiologists now are just as good at picking up new lesions without contrast as they are with the contrast. So I think if there's a silver lining to what you're dealing with, a lot of the symptoms that someone with fibromyalgia, other autoimmune conditions, MS, the symptomatic management really may be the same across all of those conditions. So having an MS diagnosis or not really shouldn't change necessarily your symptom management, whether it's pain, fatigue, any of those things. What the diagnosis would really change is, do you need to be on a disease modifying therapy or not? So I hope that helps some. I know it's frustrating. Humans deal a lot better with the known than the unknown. Even if the known is a diagnosis that's serious, it still gives you an explanation for what you're dealing with. I wish you a lot of luck.
Our next question comes from Teresa. Hi, Dr. Thrower. Been on hydrocodone 10/3/25 for about 13 years for MS symptoms, 1 to 1.5 per day. It's not quite cutting the mustard anymore for my chronic pain, which can be debilitating. Because it's so controlled, should I be going to a pain specialist about this now? Thank you.
So it's really going to depend upon the comfort level of your MS healthcare team. That they may feel comfortable pursuing things, in addition to or instead of the hydrocodone, or they may want you to go on over with a pain specialist. We're blessed here at our MS center that we have a pain institute right across the hall from us, so we use them quite a bit. The challenge with things like hydrocodone is that if at some point it starts becoming less effective, you may be developing some tolerance to it. And if we go up on the dose, you may just repeat that cycle over and over again. Granted, you've been up for 13 years, so it's not like you did it quickly. There are some, there's certainly a lot of options out there for pain management. If it really comes down to you've tried every non-opioid painkiller and only an opioid is going to work, you might talk to your healthcare team or the pain specialist about a long-acting opioid. There are things out there that you can use that have last a long period of time, so you're a lot less likely to have issues with tolerance and or addiction. I know fentanyl's got a bad name right now just because of the illegal forms of it, but the legitimate form of fentanyl patches are something that have been used for chronic pain management. They're good for 3 days. That you have a nice steady level of the drug. There's another medicine called a Butrans patch, which is a nice sustained release sort of medication. So yeah, hopefully that helps some.
Actually, while we're on the subject, I have a question. Can you tell us what a pain specialist is? What do they do, and when should people see them?
Yeah, great question. So they come in a lot of different versions. So some pain specialists are anesthesiologists who have done special training in pain management. Some are neurologists who've done special training. Some might be internal medicine doctors who've done pain training. Some are physical medicine and rehab doctors. Our pain specialists here at Shepherd, where I'm at, are all physical medicine and rehab doctors who've done the special training. So they are going to work with people on chronic pain, and they sometimes have different areas of focus. Some are more procedurally based. They're going to really want to work more with neck and back pain and do things like epidural steroid injections, nerve root ablation. So they're very procedure driven. Others are more comfortable working with medications and are not just procedure driven. Some pain institutes have physical therapists, built in. A lot have psychologists to help people with, either dealing with chronic pain psychologically or look at things like biofeedback and other kind of, non-medication or non-procedure ways of managing your pain. So they do come in a lot of different versions. Some pain specialists have gotten kind of a bad rap in the past as being kind of pill mills, and those I think have become a lot less common with tighter regulations on prescribing of controlled substances.
So when should someone see a pain specialist?
I think, again, that's going to depend upon your individual MS team. You may work with an MS team who has very low comfort dealing with chronic pain, so they may refer you on very quickly. Others, have a much higher level of comfort, or maybe you are in an area where there's not a great pain clinic, so that MS neurologist by default has to do more pain management just because maybe there aren't the resources to send someone out. So you're going to find a wide range of kind of levels of comfort with your MS team as to when they're going to refer you out.
Our next question comes from Anonymous. I was recently diagnosed with type 2 diabetes, and my doctor mentioned possibly starting me on metformin. I have heard that metformin can benefit people with MS. Is that true? And if so, how?
Yeah, so metformin is another one of those drugs that is being researched. It's a repurposed drug to see if it may actually have anti-inflammatory effects, or maybe even other benefits in MS. I think the jury's still out right now. I think because metformin has, it's not a risky drug, but it has potential side effects. I would only use it in someone like her setting where you're using it to treat type 2 diabetes, maybe in women who have polycystic ovarian syndrome is used commonly there. I'm not ready to start it as an MS therapy if I don't have some other reason to use it, because I think the research isn't quite that far along yet.
Just want to remind everybody that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute to ask your question. And as it so happens, we have another question from Michael. Michael, whenever you are ready. Michael, are you there?
Yeah, okay, I'm here.
Right.
There's anyone says since the cannabis is not as regulated as tightly as it is around here, they did do a study of cannabis and spasticity. And according to them, it's not that beneficial. Now, what is your experience down there in Georgia? Since I know it's medical marijuana is allowed down there, what has been your experience using cannabis for spasticity?
So I think in the right setting, it can be effective. And so realize there's a difference between spasticity and spasms. So spasticity is kind of the chronic state of the muscle being tight. Spasm is kind of a wave of sudden muscle tightness. Cannabis seems to be more effective for spasms than it is for chronic spasticity. It also depends upon how you measure things. So some of the negative trials for cannabis have looked at something called the Ashworth scale. So that's an objective scale for measuring spasticity. It doesn't measure spasms. To my knowledge, no study of a cannabinoid using the Ashworth scale has ever shown that it has an effect on the Ashworth scale. And so if I think that's the wrong measure to use for a cannabis study. Using things like spasm counts, patient quality of life are probably, and just overall functioning are probably better measures for cannabis. Just like anything that the human experience with cannabinoids is just like we see with baclofen and tizanidine. You've got to look at not only the effectiveness, but the side effect profile. We see individuals who tolerate fairly high doses of cannabinoids like THC and don't seem to have a lot of psychological side effects. And we see other people that just at even small doses, they're either sedated or they're getting high from it, or sometimes they have unpleasant psychological side effects like paranoia. So it really, I look at cannabinoids just in the same way I think of baclofen and tizanidine. Start with a very small dose, slowly titrate up, get away with as little as possible. But we do see benefit in a lot of individuals.
Thank you.
Thanks.
Thank you. Our next question comes from Mary, and this one looks like it's going to be a long one, so hang in there.
All right.
Yeah, my gait is on my right side. I'm sorry, my gait on my right side is compromised due to spinal cord lesion. I have always followed an aggressive exercise regimen in an attempt to remain strong. Yesterday, my chiropractor suggested a lift from my right shoe to balance out my gait. I'm open to suggestion, but I'm wondering how you think I should proceed. Is this something that I should have evaluated by a neuro PT? I'm uncertain how to proceed for a proper evaluation. Your thoughts would be appreciated.
Yeah, I would strongly recommend seeing a physical therapist who's familiar with MS. Therapists who have worked with spinal cord injury, stroke, really anything that affects the central nervous system can also work with MS. What happens a lot of times with MS is the hip tilts one direction or the other. So the one leg looks relatively shorter than the other, but it's really not a leg problem. A lot of times it's a pelvic tilt that's causing that. And sometimes physical therapists can correct the actual tilt rather than just putting a lift in the shoe to kind of, put a Band-Aid on it. So yeah, I would highly recommend getting in with a physical therapist before you commit to the lift.
Our next question comes from Wendy. Please explain the difference between tremor and essential tremor, and how is each treated?
So tremor is the big term. So there are a lot of different types of tremors out there. So you can have what we call a benign essential tremor. So that's unrelated to MS. It's probably one of the most common tremor types. That's going to be a tremor that it tends to affect the hands, maybe the head and neck, sometimes the voice. Think Katharine Hepburn, that the kind of the warbling voice that she had, that was from a benign essential tremor. Again, it's not due to MS. It's not dangerous, but it can certainly be bothersome to people. We tend to use beta blockers, things like Inderal or propranolol. There's an old anticonvulsant called Mycilene or Primidone that we sometimes use. The bad thing about both those medications is they can be a little bit sedating. So we have to kind of balance the good and the bad. Sometimes occupational therapists can help with benign essential tremor with adaptive equipment to help with things like eating. Sometimes using a weighted utensil will help calm the tremor down when you're eating. The tremor that we typically see with MS is usually more of a cerebellar tremor, and it's a big tremor. And so it tends to cause, when you try to reach out and touch something or grab something, the closer you get to the object, the bigger the tremor gets. Can also affect the trunk so that people can have trouble just maintaining an upright posture. They tend to have what we call titubation, where they tilt and have a tremor of the core itself. That's a rough tremor. It doesn't tend to respond especially well to medications. We do use a lot of our physical therapy and occupational therapy for that. Other neurological conditions can be associated with tremor. Parkinson's disease, you commonly see a resting tremors. When the hand is at rest, you kind of get this pill rolling type motion. Some tremors can be treated if they've not responded to medications with a procedure called deep brain stimulation. So this is kind of like a pacemaker that's implanted here with micro electrodes that actually drop down into the deep part of the deep gray structures in the brain to basically electrically override the tremor. It's most commonly used for benign essential tremor. I have seen it work for the cerebellar tremor with multiple sclerosis as well.
Our next question comes from Linda from Facebook. Before I go ahead and ask her question, she says Dr. Shepherd in her question. So
I've been promoted.
Yes, I'm assuming that she either means to say Shepherd or the doctors at Shepherd. So with that having been said, I will read her question as it has been received. Does Dr. Shepherd offer telehealth out-of-state patients?
So yes, we do. We try as much as we can to see someone at least once in person, just to really get to know that individual. But we have on some occasions, if transportation is just really difficult, we have done telehealth, and we are allowed to do telehealth as physicians across state lines. Just realize not all specialties can do that. Our physical therapists and occupational therapists, for instance, cannot do telehealth across state lines unless they're licensed in that other state, but most physicians can. So it is possible that we can do that. Again, we'd like to lay eyes in person at least once if we can, but we understand that sometimes it's just not feasible.
So just a reminder to everyone, if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you so choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute to ask your question. Our next question comes from Anonymous. With cases of COVID rising, what is your current recommendation on getting another booster?
Yeah, that's a great question. So COVID has been this ongoing moving target. We've dealt with so many different versions. So we are still dealing primarily with Omicron variants. They are certainly contagious. The good news is they are not quite as serious as Delta was. That's not to say that it's not something we take lightly, but thank goodness we're not seeing the hospitalizations and deaths that we did with Delta. The decision to do the new bivalent boosters, I think, is a very individual one. They do offer protection. There's just no getting around it. The challenge is the virus continues to mutate, so it's very likely that our vaccine strategy is going to continue to evolve. We're going to have to make new versions of these vaccines to keep up with the changing virus. The challenging group of individuals with MS are people on B-cell therapies. So study after study has shown that most people with B-cell therapies, Ocrevus, Kesimpta, Rituxan, these Briumvi, are not making a lot of antibodies to COVID vaccines. You still make a T-cell response. We just don't know how protective that T-cell response is. So we were offering antibody therapy, things like Evusheld, to people on B-cell therapies, with the thought being, if you can't make the antibodies with vaccination, we'll just give them to you. Now, Evusheld has had its emergency use authorization withdrawn because it became ineffective against the new COVID variants, and no one has stepped up to the plate and made Evusheld 2.0 or Regeneron 2.0. So we don't currently have an antibody option to replace vaccines for people on B-cell therapies.
Our next question, maybe more of a comment. It probably requires some expansion, but I have a comment here from Bob. 2 words: extensor spasticity.
Yeah. So when we have increased tone, which is what spasticity is, in the arms, it tends to be flexor. So our arms want to do this. In the legs, it tends to be extensor. So your legs stiffen out. In the trunk, if you're going to have spasticity or spasms in the trunk, it tends to be extensor. So that's just, now there are people who their central nervous system didn't read the textbook, and they'll occasionally see flexor spasms in the legs, but usually legs, it's going to be an extensor spasm. We talk about spasticity as if it's always a bad thing. There can ironically be a good side to increased extensor tone. If you have weakness in your legs, a little bit of extensor tone can actually be useful to compensate for weakness and help with things like transfers. If you have so much extensor tone that, we use your extensor tone to transfer you from chair to, say, car, but now you're in your car and you can't bend your knees and your legs are straight out. Well, that's too much extensor tone. So with spasticity, we do like to get physical therapists involved early on to help give us some guidance about is any of the spasticity that we're seeing actually helping the person's function, and do we need to be cautious about taking all of it away?
Our next question comes from Jim. Is it advised to take magnesium to assist the body with vitamin D absorption? As a side note, our phone's down at the Shepherd Center due to storm.
Not due to storm. So our someone was doing work outside of Shepherd and cut 2 major Comcast cables. So we have no phone service, no internet service. We had no electronic medical record up until a few hours ago. Fortunately, they got that back up and running. So yeah, it's been an interesting day here with no internet. It's supposed to be back up and running in the next few hours, though. Magnesium may help with vitamin D absorption, but I don't think it's a have to, because we're monitoring vitamin D levels, and I can tell you, we get vitamin D levels up into our desired range without magnesium, without much difficulty. We tend to use magnesium more in terms of migraine management. It can certainly reduce the risk of migraines. There is data out there suggesting that it might support central nervous system health overall. I'm not going there quite yet. I don't think that I'm quite convinced by that research. So yeah, I don't think you have to take magnesium to get your vitamin D levels up where you want it to be.
Our next question comes from Elizabeth. I have PMS. It's been several years since my annual MRIs included spine. I have asked that after this, they ordered C-spine, T-spine with contrast. Do I not have new, only worsening symptoms? Do I need contrast? Thank you.
So primary progressive MS is much more of a spinal cord issue than a brain issue. So a lot of people with primary progressive MS can have pretty unremarkable brain MRIs, or maybe even no lesions on the brain MRI. Primary progressive MS is not as dynamic on MRI as relapsing forms. Meaning the MRI doesn't change as much in primary progressive MS, even though the person could be getting worse. It may not reflect on their MRI. I don't feel strongly about contrast on MRI for most of our patients. And the reason being that what research has shown is that with newer MRI techniques, we really are seeing most of what we need to see without the contrast. I wouldn't fault anyone for ordering it, but I'm just not sure that it's absolutely necessary. It's very unusual to see enhancing lesions in someone with primary progressive MS. And so I personally wouldn't feel strongly about doing the contrast in her setting.
And on a related note, we have a question from Gus. I have recently changed neurologists as my old neurologist retired. My new neurologist wants me to get an MRI every 6 months with no contrast and a neurofilament light chain test every 6 months. The cost isn't that high and doesn't break the bank. Is it worth it? Does it provide any benefit?
So we typically do MRIs on a yearly basis. If you're thinking about doing MRIs on an every 6 month basis, it usually means that either the person is changing, you're having new symptoms or progression, and we want to kind of see if anything's going on the MRI, or we're changing their therapy and we want to see make sure that change in therapy didn't lead to new lesions. So I would say it's not wrong. It's just unless there's been a change in therapy or a change in your clinical status, it's a little more than is typically done. The neurofilament light chain has kind of been one of the topics that's been brewing now for several years. We're looking for surrogate markers, biomarkers, blood tests that would kind of supplement or maybe someday even take the place of things like MRIs. I don't see us getting rid of MRIs, but there's certainly that desire to have blood tests that can give us another window into what's going on with your MS. Neurofilament light chain can be measured in the blood or in the spinal fluid, and it is a measure of whether nerve fibers are being degraded. So it does correlate with relapses. It correlates with progression of disability. So it's not. I think what you'll see across the MS world is it's being adopted by some folks who say, yeah, I think I'm ready to put this into clinical practice. And others are saying, nah, I don't think we're quite there yet. I don't know what to do with that information. It is interesting. A lot of research projects do neurofilament light chain as part of their outcomes measures to see how effective their therapies are.
Our next question comes from Maria. I was diagnosed in 2014, but I haven't had any symptoms in all those years. I am not taking any drugs. I am seeing muscle fatigue when working out. How do I determine if it's MS or age? I'm 52.
Yeah,
Do I take drugs looking at Kesimpta or slow progression? I
mean, it's not wanting to sort of read too much into what she's saying, but I mean, if she's been dealing with this for 14 years and she has minimal symptoms, assuming that she has a stable MRI to go with that, I'm not sure that I would start a disease modifying therapy. You could argue maybe she's in that 1/3 of people that's just going to follow a very mild course, and we can focus really on just managing any mild symptoms or dealing with quality of life issues. Her question about sorting out what are normal age-related changes versus what are MS changes, that's a big challenge. And so certainly, as we get older, I can tell you as a 60-year-old, there are things my brain says I can still do, but when I try to go out and do it like I did when I was 20, my body says otherwise and says, no, you probably can't do that anymore. I think regardless of whether it's age or MS or a combination of both, I would still push to stay as physically fit and active as possible. Very few of us get the amount of exercise that we probably should. And so we all can probably do a little bit better. And most of us will function better as we get into a better exercise program.
Our last question. This one comes from Anonymous. I am trying to understand the recent research update that discussed being cautious about using probiotics while on B-cell depleting DMT and taking multivitamins only a few times per week. Can you explain this?
So the idea, with probiotics is, across probiotics, there are a lot of different versions, in terms of how many strains of bacteria they have. And so the thought of being cautious would be if you're taking something with a lot of, in theory, good bacteria, but still bacteria, and you have a relatively suppressed immune system due to the B-cell therapy, could we open you up to some sort of bacterial overgrowth or sort of GI infection that we don't want to see? The vitamin theory, I personally, if someone wanted to take a multivitamin every day, I don't oppose that necessarily with a B-cell therapy. You could argue that do any of us really need a multivitamin? There have been a lot of nutritionists who said that average person with a decent diet probably doesn't need a multivitamin, but I think most people don't hurt themselves by doing one. So I can't say that I make a distinction with multivitamins between B-cell therapy or non-B-cell therapy. But on the other one, the thought on the probiotics is because you're potentially mildly immunocompromised.
We have reached the end of our time today. If you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings or sign up for our newsletter to learn more about our upcoming events. Be with us next time when our teleconference will be at 6 p.m. on August 16th, when Oscar the MS Monkey will discuss transitioning from pediatric to adult neurology. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Ben Thrower. Thank you so much for the time you spent to prepare and share this information with us.
Thank you, everybody.
We greatly appreciate each of you filling out our post-event survey, which will be available as soon as you leave this conference. Your participation in the survey will help us greatly in creating meaningful programming for the MS community. Goodbye, everyone, and we look forward to seeing you again next time.